CCLS, that is comprehensive cardiac life support, use a step-by-step approach for cardiac arrest, in-hospital cardiac arrest, and to be performed by paramedical and medical personnel who are trained in it. And what is the need of separate guidelines? The point is CPR guidelines were formulated and designed by Western world, and the data is from the Western world, and they are implicated for the Western world. And they have, that is a very elaborative and detailed guidelines, and which is not possible for a normal person to go through it routinely. And there is a long periods of training to get confidence in those guidelines. And this depends on expensive training, and resuscitative equipment are needed to train the personnel regarding these guidelines, Western guidelines. And they are not easily communicable because they are published in English and they are not published in our local languages. And there is no availability of automated external defibrillator AED devices that commonly in our country. So incorporating AEDs in the routine guidelines in the BLS and for routine laymen may not be of much use, and training and certifications are unaffordable by the laymen who are in our streets. And due to cultural beliefs, like majority of the people are hesitant to undress the person or perform mouth-to-mouth resuscitations, the Western guidelines may not be appropriate in all the conditions. And the guidelines that have been framed by Indian Resuscitative Council, the target group, they are designed as per the level of literacy, the knowledge and understanding of the person who are being taught, and they are color coded and they are integrated and they are standalone so that they can be easily taught to the general population also. Indian Resuscitative Council has categorized CPR, BCLS for school children, layman, MBBS new entrants, and compression only life support to teach school children and laymen, and cardiopulmonary life support, basic cardiopulmonary life support for paramedics, ambulance staff and doctors, and CCLS for doctors and paramedics. And this is a group photo of Chakra Rao Garu with dignitaries.
Dr. Vinay Nadkarni, the chairman of ILCOR, was there. He is the person who has on the right that shirt, blue shirt, is Dr. Vinay Nadkarni. He was chairman of ILCOR and previously was chairman of AHA also. Now he is the chairman of the International Resuscitation Board. Okay. He is frequently attending our ISCCM conferences. Okay. This is a photo when we attended the Cape Town on their request. And there we have shown about 5 lakhs trainings in a year. So we had a photograph with them. Next. These are all our publications. Publications by the, meanwhile, in 2018, they have started a World Restart a Hard Day. This World Restart a Hard Day is the proposal of the European Resuscitation Council to everybody. They have gone through all their legislators and got it signed and started, and they have asked us to participate in that. In the first instance itself, in 2018, we have done about 2 lakhs trainings for the school children and all. And we are training this COLS, compression only life support. And next year we did about 5 lakhs this one. They are also insisting not only the hands-on training, but also the lectures through FM radio or TV or even the publication. Just you make it well worldwide. People should know about what is what. People, even though it is not a very effective compression, some sort of compression is better than no compression. Because a place like India, where we wait for an ambulance, where we wait for making the victim to sit up upright and make him to drink water, it is not the way. You make him lie down and start chest compression even without seeing the pulse. Because seeing the pulse, even for doctors, it is difficult when there is a doubt. So and seeing the carotid pulse is more difficult for a layperson. So we are not bothered about that. So this is the thing. Next. So he has given a letter that appreciating me at that time. Next. In 2020, when there is a big COVID, we wanted to popularize ourselves. So I got one of the Director General of the Postal Department. So we have released one, he came to Kakinada. You have released one first day envelope here. Next. This is the first day envelope. Of course, this is this type of postal stamps, even we can get it done with our photograph also. This is done. Next. This is our Vice President, actually, he has released that BCLS training manual at the Swarna Bharat Trust near Vijayawada. Swarna Bharat Trust are four, Swarna Bharat at Chennai, at Hyderabad, at Vijayawada, at Bangalore and all. He is there. Next. This is actually, when we are going through this, the Vinay Nadkarni, the chairman of the ILCOR, has advised me, it is not the only anesthesiologist that has to do it. There are a lot of many specialties that are involved in cardiac arrest, and he is stressed on the emergency medicine. At that time, there is not much of an emergency medical physicians available. And in 2022, only the government has made it mandatory to have an emergency medicine department in every medical college and hospital. So at that time, so we have gathered all the people. It was a very tremendous big task for me to approach the cardiologists. Of course, Indian College of Cardiologists have come forward. The critical care people, Rajesh Mishra has come forward at that time. This is all with a lot of effort for 2 years. And emergency medicine, there was a hit, and we created an association of emergency medicine educators, and that is another society. And IMA has joined. The pediatricians have joined. So the PALS, which is there, it will be now the Indian PALS, because we don't. Our first aim is to decrease the cost of training. It should not be in thousands and 10,000s and 20,000s. It should come to hundreds, about 1,000 rupees or 1,500 rupees or something like that, because their books and everything are very expensive, and we wanted to make it available, and we want to make every medical college a training center, so that the people will be trained on their own. And we went next time. And this is in the curriculum, DNB curriculum. We tried and got our BCLS and CCLS incorporated. And even in the ISCCM courses, now the BCLS and CCLS is mandatory. Previously, only the ALS and BLS are there. Now it is approved, and we made it mandatory. Next. This is regarding our society. It is, we have 12A and 80G. Of course, we are not collecting any donations now. Actually, let our be strengthened by our work for another 3 years. Already 2 years is over. And then we, if anybody comes and gives some donation to train these school children in his village, we can go out and we can employ. Next. And this is the journal. Actually, we have curtain raised last month, and already we are collecting the articles. Of course, this is an online journal, only 2 issues per year, and this has costed us quite a lot, because we do not want, we want it in a very good digital platform like so we have requested the water blower. They have charged about 4 lakhs for this, and now we are collecting this one, because it is not a index journal. It takes about 3 years to get indexed. So we are asking some review articles and some case reports to be published, and we are collecting it. And I think we will bring it because this is the second journal in the world that is on resuscitation. Next, sir. These are all the people actually, we're all actually with a lot of work and pressure on the ILCOR, they have all inducted as the committee members here. Here, if you see, Dr. Rakesh Garg is a ALS task force member. He will be attending every 2 weeks, he will be attending online discussions on the modifications of the guidelines. So whatever you think is AHA guidelines, is ILCOR guidelines, he is attending. And this man is Lokesh Tiwari. He is from the All India Institute of Rishikesh now. He is a pediatrician. He is in the pediatric. Now other people will be there. I am in the chairman of the World Restart a Heart, and this is Mukul Kapoor is a communication company. Mukul Kapoor is a renowned cardiac anesthesiologist and the HOD of the Amrita Hospital of Hyderabad. Now this is Akshama Sharma. She is also a member of a diversified committee. Actually, these committees, what they tell is you involve more women, you involve more different kinds of people. Even now, I have 2 women, I have 2 from north, 2 from south, and all like that. And I wanted to introduce a Muslim like that because there should be a diversity. And this is a lady. This lady is the registrar of the Trained Nurses Association, Andhra Pradesh, and she is contributing a lot. And this is Lokesh Hedra. He is from USA. He is a junior to me in Kakinada as a medical student. So he encourages us. Sometimes he pays the money and for certain things, and he might have spent a lot of money. With his own money or the money from the OPI, he has sent us to South Africa and all those things. So he's a backbone for us. Next. So now, 26th October 2024, we are providing an annual scientific conference. Actually, New Delhi. Next year, actually, they have asked, the ILCOR has asked us to host an international meeting of ILCOR. So probably they will be, we are ready, but they told us you upright. Actually, they have offered us, we have accepted. Now the Korean people are also asking to join that. And probably the 2025 guidelines of AHA or ILCOR will be written in India on 26th of October 2024. Next. So we have a lot of deficiencies here. So what I feel is whomever we have trained, whether if there is a 108 or 112 is introduced by the government of India, but a first responder training should be there. And the first responder should be attached for a GPRS. He should be located. And he should be instructed that there is a problem of cardiac arrest somewhere. Just like our Ola or Uber cab is going, when there is a necessity, a person should go. This is my feeling, and this one. And another thing is a telephone CPR. You can telephone him and all. We have seen many incidences, many issues that many VIPs getting chest pain and waited for the ambulance. Nothing was done, and almost all are brought dead in the recent past. So that was another problem. And another, we have approached the CBSE, Central School of Education, and all them we have seen that all these things is included in the curriculum of 9th class. So if the 9th class students are trained, definitely his family will be safe. They can, and these school children are very active, and we can save them we can train them as very easily. And another is school teachers. We have to form a PET teacher can teach this, and we can make life-saving clubs and all. These are all the things we are promoting to the government. And another thing is for the flats. There are 10, 20 families are living in high-rise buildings and there is no AED. Now we have requested the government to not to give an NOC for occupation of any new flat unless they show you an AED. AED is after all costing about 80 to 1,20,000, and definitely one can afford to save their lives. And a mandatory certificate of AED should be there, and all the public establishments, malls, convention centers, hotels, parks, and all. Whenever, even in our hospitals, we will not be using AED, we will be using a defibrillator. And the defibrillators are placed in the most highly dependent areas like emergency rooms or operation theater or the ICUs. But others in other wards and in the areas, ground areas, a lot of people will be moving and there is no protection. And I don't think these AED can reach them in proper time. So what we want is one should be trained for the compression only life support, the COLS, then only they can save. And another thing I came to know that in Singapore, every staff member will be given a slot on one day. So he should go to a mannequin, train, compress himself and qualify himself, take the certificates once a year. Then only we can make the 120 compressions. Next, sir. Now I have an idea because our ambulances are stuck up in the traffic and we are not able to do. So an AED may be transported with a AED by a drone. So that is a good idea. But of course, we have to induce these ideas to our politicians and the IAS officers. So mandatory training to all the ROGC hospitals or all the staff. Of course, in Andhra Pradesh, the medical college, they are doing for all the staff. And the government of Andhra Pradesh has made it mandatory. They have even paid us to train their staff. Of course, I said, I'm not going to train. I will send you the material and everything. All our medical colleges have got the training centers because first establishing a training center has become a big problem because the cost of the mannequins. So now the mannequins cost has been decreased. Now some people, they are preparing the manufacturing, trying to manufacture the Indian mannequins, but the quality, I don't know what we can see. And the mandatory training for and not only that, with the medical registration, we have about 30 points for every 5 years to renew the medical registration. We're also insisting on the CPR training, renewal of the CPR training at least every 5 years. Actually, it should be registered every 2 years. And police and ambulance and the truck drivers should be trained. Next slide. This is actually 27th is the day when our beloved former president of India, Abdul Kalam, has succumbed to sudden cardiac arrest when he is giving a lecture in the IIM of Shillong. And nobody could revive him. So we have written letters to Sri Modi ji and the President of India to make this week as a national CPR week. So we are doing it. And this is actually, our program is also a part of National CPR Week. I can proudly say that Yashoda Hospital has conducted this program to remember the deeds of Abdul Kalam. Next, sir. So 16th October, just like our World Heart Day, the World Restart Heart Day is a grand event we are celebrating. Actually, this is also done once in 1 month a year. but I have changed it. I requested them. Now, because I'm doing good work, I have some position there itself. So now we are starting from January to December 1st. So 1 year December because of their leaves and all those things, and for Christmas is all right. But 11-month trainings will be counted, and will be and every year we will be presented. All our presentations in either Elsevier Journal or AHA journals. Next. 1st June 2000, we were unanimously voted for membership of IRCF in ILCOR. Next. This is a letter of recognition. Next. This is actually, my name is already there on the left side as the chairman of the from the chairman of the Indian Resuscitation Council Federation. And so for all these years, we have people from American Heart Association, Australia and New Zealand Committee on Resuscitation, European Resuscitation, Heart and Stroke Federation of Canada, and Inter-American Heart Foundation, Resuscitation Council of Asia, and Resuscitation Council of South Africa. And India and China has no place actually. The people who are having 1.4 billion population and even more have no place. Actually, they have asked me to join the Asian Resuscitation Council. I said it is not possible because in the Asian Resuscitation Council, Japan, Singapore, and Korea are there. And their situations and things are different from what we have. So we will have our own. Then of course, they have accepted what we have said. Next. This is the day when we attended a Brisbane meeting, and they have congratulated us to get the membership in ILCOR. ILCOR membership is really a pride for India, and even now we wanted to make the trainings at a very, very, very cost-effective price. And when you say that we have to train a nurse, actually we are paying about 12,000 to 15,000 for a nurse. And if they go for the training on other councils, actually their salary will go away. So, and it should be available even for free. It should be available even for free. And all the school children should be trained free. Then only we can save. Actually, in Seattle, 95% of the population are trained. And actually, in one of the slides, it was saying the success rate of CPR is only 46%. But in Seattle, 65% of the victims are saved because all the 95% of the individuals are trained in CPR. That is their success. Next. So this is Make in India.
Just thank you, Chakra Rao sir, for that information which actually Siddharth was trying to say. Siddharth, you have gone through the presentation of both the sites, like you have been a part of HA, BLS, ACLS, and also now you have been also seeing Chakra Rao sir's and his team's effort, and now we are also be a part of internationalizing Resuscitation Council after a lot of efforts. So what is, as a clinician, you have been exposed to this all information today. So as a clinician, what is your perspective for this?
These guidelines, both BCLS, CCLS, and COLS, are very comprehensive, easy to understand. And I'm very happy that I have, for the first time, I have been reading this, but I felt that is much useful even for a first-time reader. And I could not understand 1, 2 things. I could not see the pediatric aspects, pediatric algorithms, and I could not see the tachyarrhythmias algorithms that we usually see in AHA books. And regarding pregnancy, we usually see a algorithm in ACLS, the American Heart Association books.
Yes. This is actually a preliminary version of this. And we have added some annexes for this. And actually today we are reviewing the books again. And you send me your address on WhatsApp. I will send you a few books. We have annexes also for arrhythmias and all those things. And I will send you the PowerPoints of the CCLS and other things also, where we discuss about the airway, where we discuss about the pharmacology, about the drugs and isopropyl and all those things, and where we discuss about the RYC and the temperature lowering of the victim, and where we discuss a lot about the arrhythmias and pre-arrest conditions. How we have to identify the pre-arrest condition, which is more important. We have to teach the nurses. And by the time when we suspect a pre-arrest conditions, they should be ready with the crash cart and the AED, everything charged and everything. So that is another thing. And here there are certain differences. What I wanted to tell you here.
We will come to you, Chakra Rao, sir.
Yes.
We will come to you because you have to inform us all those things by step. I just wanted to learn from Siddharth from his perspective. So the first point which I gained is many of our clinicians are even not aware of these guidelines in details. So there is a lot of work need to be done in awareness on this, because that is the first point what I picked up from Siddharth. I believed for me as a clinician, the most striking feature in your guidelines or Indian Resuscitation Council Federation guidelines is simplicity and reproducibility. This can be applicable to the rural setup where there is nothing else. A chest compression can be done till a vehicle is arranged to reach to a nearby hospital. These two things actually made me impressive about this whole. So taking you forward, sir, these all were there since almost 2-3 decades from our medical school days. We have been learning somehow in all our graduation, medical schools and post-graduation. These resuscitation skills has always been ignored, even though we read from the anatomy to medicine to a super specialty divisions. Even the basic resuscitation skills has not been taught as a mandatory phenomenon in medical schools. This is not now. I think this has been happening to 60 years, and there has to be a subject on resuscitation skills, and there has to be a mandatory training. What is your take on that, sir?
Actually, nothing is taught in the medical school about the resuscitation. I was a postgraduate student from 1977, and in none of the anesthesia books or physiology books, they have not mentioned about the resuscitation. But recently, Miller has mentioned about this. And another thing is AED. And many places, AEDs are not available, and I have not seen even one AED unless it was sent by one of our NRI student from America. And it was always kept in our old student guest house, locked up. So if you come to my house in Kakinada, my AED is there on my wall, open for, because I have learned, I could do it. Otherwise, if you don't do it, it is the habit of our professors. When new equipment comes, they will keep it in the cupboard and securely lock it up. And another thing is, all these things should be in the regional languages. I requested many of these people who are manufacturing the AEDs to change the language. Then they said the English and Hindi. Okay, English and Hindi is all right to a larger extent, but in South India, all the 4 languages should be there. We cannot understand Tamil, we cannot understand Malayalam or anything. Then they are convinced, and some of the doctors, even the anesthetists, are coming out to manufacture and to change the chip. They are telling it is very easy and we can do it. And I requested one manufacturer in Chennai, that Labdab, Appaswamy, he is manufacturing, he is changing the chip, and he brought a Korean version and changing. and like that. And even the our PowerPoints of COLS should be in Telugu. Because some of the, however, they are even the BSc nurses, sometimes they are not able to catch up. It should be in the regional languages. And we have a very small 3 minutes video. Actually, it was not there. That is, we have done it in 10 languages, including Urdu. Including Urdu, we did it, and including Kashmiri language. We wanted to promote it with pride, and because if I do it in Kashmir or Andamans, the people will be appreciating more than doing it in Hyderabad and Chennai. So that is another thing. One more thing, what we wanted to teach is the QCPR. What is QCPR? Is the qualitative CPR. We advise that we advise 120 compressions per minute when the ILCOR advises 100 to 120 compressions. We have proved it by literature that 120 compressions is better, because if it is 100, they may stop at 95 or 90 and they may not come. If we make it 120, they will definitely compress 110. So it is not easy to maintain the rate also. And another thing is the 2 centimeters depth or 5 to 6, 2 inches depth or 5 to 6 centimeters depth with adequate recovery, adequate recoiling of the chest and everything. And another thing is everybody advises the mid-thoracic compression and the mid-thoracic region. But we always, you identify the Jeffard process and you measure 2 fingers breadth above the Jeffard process and keep your dominant hand on the sternum. So the compression should be on the sternum, and the heart should be compressed between the sternum and the vertebral column so that it pumps adequate blood to the brain and make the victim alive till the help comes. So that is our this thing, and we have not never stopped the compression. If at all you have to stop, it is only 7 seconds or 7 to 10 seconds, and nothing more than that. But we have oxygenated blood in the body that has to be reoxygenated as we compress. So when you are compressing, the air in the lungs will go out, and we make a recoil. Definitely it will bring back the air because of the negative pressure in the intrathoracic region, and the air has got 80%, 20% oxygen, which can easily reoxygenate the thing. And even regarding the mouth-to-mouth breathing or risk breathing, it is advised that after every 30 compression, there should be 2 risk breathings.
Rescue breathing.
Rescue breathings. And sometimes when you are outside, when you don't have an ambu bag, when you don't have a ventilator, and when you don't have a pocket mask, it is very difficult and it is dangerous to make a mouth-to-mouth breathing because of the COVID. Not only COVID, AIDS is rampant, and even hepatitis C is a problem. In these circumstances, what we say is, even if you don't make a rescue breathing, there is no problem. When you are compressing, you will be compressing and getting about 70% of the tidal volume, and that will be adequate. And some sort of stenosis will occur in the long run. This will be helpful for the immediate release of the oxygen to the tissues. So this is the thing. Actually, there is another video also. Actually, it is made by Joel. Joel is a Japanese company which manufactures these things. And I have written to them, and they have given me the permission to use and all. I wanted to change the language also. Of course, it is in English. I wanted to change the languages to Telugu. I am taking the help of Rajit Karthike.
Let me ask you for a few questions, sir. There was some audience question. Let me ask you a question. Yeah, what actually triggered in your mind to create a national guideline or Indian guideline? Which point is the trigger point for you when you and started working on it, and what is the history and story behind it, sir?
Actually, the Indian Society of Anesthesiologists is thinking it since a long time, and it has failed twice. And after this publication in the Times of India in 2016, that 98% of the Indians do not know about CPR. Then the president of the Indian Society of Anesthesiologists is of course my junior. I am the past president at that time. He has asked me, why don't you start this? So he nominated me as a coordinator, and whatever money you wanted to take. Then immediately I called for about 40 people. I called them all to Hyderabad because it is the center of India. So I called them all and I told them, you please come and attend. I will book a room and I will give the hospitality, but I am not going to give the flight charges. So about 40 people come, and many of them, of course, that photo is not there, who has attended. Dr. Rakesh Garg, Dr. Rashesh Devan from Ahmedabad, Dr. Syed Mohid Ahmed from Aligarh Muslim University, Divyatia, Dr. Murali Tondabedu from Bangalore. Of course, our Murali is there in Hyderabad, and Dr. Tanmay Das from Calcutta.
All of them came. So, and is that the point starting Nidus?
Yes, yes. That is 16th of April 2017.
Okay.
And all of them in the same thinking that we should not charge much and all those things. It should be make it available to the public and all those things.
So when you actually started thinking about your own country's guidelines, what was the unique features you had in your mind, and how you translated that?
Actually, I don't have anything in my mind. These people, finally, I decided to give this task to Rakesh Garg and those people, including Baljit Singh. You decide. Then they thought, and they have come to the conclusion that they have gone through, because this literature is coming from 1966, since AHS started. So they have gone to all the literature that was published and separated those articles that have come in the low resourceful areas, and those articles they have taken, and they have taken the idea from that, and that they have started this COLS. Actually, this COLS, the mother of COLS is the bystander CPR. The bystander CPR in Denmark has produced great results, but because of their availability, and they have a very beautiful emergency awakening system and the ambulances and even the ventilators and everything in the ambulances, they have kept it aside. So we have taken it, and now this COLS is talked by even the American Heart Association.
So I think very interestingly, contrary to what we think, the rescue breathing standard resuscitation like BLS, AED, all this sophistication is required. There are many evidences of trials like DIRT, which are suggesting even a bystander chest compression done in a out of hospital situation till a proper team arrives or a proper ambulance or a medical helping team arrives, has shown to be equally effective, or sometimes there is a information that it may be better than the standard conventional ones where there is rescue breaths given. And I think as you rightly highlighted, the reason for better outcome, okay, equal outcome we do understand. The better outcome may be the interruption of chest compression for those rescue breaths, and the inavailability of hesitation to give a mouth-to-mouth breathing and all that. So this all could have been avoided by only chest compression, where, as you said, there is some amount of at least air in and out happening because of your chest compression and recoiling. Is that the thing which you also contemplated?
Yes, yes. Actually, the recoil, actually, I thought of showing that video from Joel, that he clearly shows how the air goes in when the recoiling occurs and all those things. And that is important. And even that we know that 75% of the tidal volume is adequate to maintain the person. So that is the one. Whenever you are a very skilled person, whenever the AED is available, whenever there is a availability of an ambu bag, we don't say no to the risk breathing, or we don't say no to weight. The earliest AED application is also good, and definitely it should be done when it is available. The problem comes is when it is not available, when you are offhand, when you are struggling to get an ambulance, and the ambulance is entangled in the traffic, where we do not have an ticket for the ambulance and all, then every person, every citizen should be a lifesaver by learning CPR or CYLS.
Why do you think, sir, 5 cycles or maybe 30 compression, 5
30
cycles?
compressions and 5 cycles. This is the minimum actually to see. And meanwhile, every 30 compressions, the persons can be, if there is a second person, they can change the positions. And meanwhile, it is the minimum first thing that we can wait till the ambulance comes. That is the thing.
Now I think we are also seeing some comments from AHA, like if a bystander not trained, insufficiently trained in CPR witnesses a out of hospital cardiac arrest and sudden collapse, he probably can only do a chest compression without ventilation. These have been new additions which you are talking about, chest compression only by a bystander. This has slowly been adopted by them.
CYLS, actually, they are now advocating it. Even after the meeting, they have sent a newsletter in 2017 itself. That and we say that some compression is enough. It is good to make them survive than no compression, than to wait till the ambulance comes, than to wait till the expert comes, than to wait till the AED comes. So we have to insist. Of course, in Hyderabad, there I think I heard that they are purchasing another 1,400 AEDs to keep it in the city centers. And previously, about 3 years back, the Osmania, Kakatiya, Gandhi Old Students Association has already donated about 1,100 AEDs about 3-4 years back. They have kept it, they have installed it in the ambulances. But the problem is the ambulance should be given a thorough green channel to travel. Otherwise, it is very difficult in cities like Hyderabad and Bangalore. It is very difficult. It cannot reach even after half an hour.
So the other point is availability of AEDs in non-metro cities. I think if you take any smaller cities or rural setups, I still believe that more than 99% of our geographic location of India must have been not have a facility of AED to be reachable. What is your point, sir? Even though we have a guideline, even though we have a BLS saying AED, if it is available, may have additional benefit of recognizing rhythm, reverting a VTVF, but availability is the biggest question. Till that point of time, I think
at that point of time, we have to
do something.
Our 2 hands will compress the chest and wait till then. I don't know how long we can compress the chest, and who will come to a risk to take a second, because it is very difficult to compress for more than 5 cycles.
So keep on changing. 2 people maybe changing one after the other.
Yes.
Maybe
after 30 compression, they can change.
After 5 cycles of 30 compression, maybe it comes around 2 minutes or so.
Yes.
So you can keep on changing. And if a third person arrives, that can be helpful for them. So
Yes.
as I was discussing just before this seminar with you, when we had the similar kind of case. So as you rightly pointed out that the movies will have a lot of impact. Indian cinema has a lot of emotional, psychosocial, and educational effect on the minds of Indian population or the citizens. So I think, as you rightly pointed out, that can be a very good media to actually spread this message ki, this can save lives. So chest compression only, without doing anything, you can be a lifesaver. I think that has to come, sir.
Your two hands can save the life is our slogan. And every citizen should be a lifesaver. So in that aspect, I request all of us to participate in training your neighbors, your family members, and your friends whenever it is possible. And even today and yesterday, Dr. Jayashree Sood, the head of the Department of Anesthesiology and Critical Care in Sir Gangaram Hospital, she is doing in her locality. And she has kept some photographs I have posted on the Facebook. Because everybody, we have to think it as a responsibility. It is not that easy because catching 140 crore people is very difficult, and impressing on the this one also, politicians also difficult. I don't know how, but the Commissioner of Family Welfare of Andhra Pradesh has called me and said, you please train all the 10,000 nurses we have. So definitely, because we have the facility already established in all medical colleges. Now the government of India has come forward with NELS, National Emergency Life Support. There also our guidelines only are kept there because whatever that is referred by the government of India will go to the government, go to the All India Institute, and Rakesh Garg has kept it there. So whatever it is, whichever guidelines, just let us practice the guidelines and let us make it available for the public to learn. That is most important. And not only the nurses, our lab technicians, our watchmen, everywhere. Everybody should be. Even I tell them, even if I go to the club, I tell them everybody should learn there. Unless otherwise they learn to do CPR, we are not.
Sir, is this CPR guidelines from IRC will be a part of NABH accreditations?
Yes, it was sent. And of course, it is not there. I have a photograph with Dr. BK Rao. And he said, okay, we'll do it. The problem with NABH is NABH is completely done by some third parties.
Yes.
They take it as a contract to make some posters, to make your records, to make it everything, and even the certificates are given by them. So that is the only thing. Otherwise, it is acceptable for NABH accreditation.
So what is the process, sir? Like HA, we have BLS, ACLS. What is the process? Suppose this is only for the audience, those who will be listening to you. Suppose you provide provider courses, instructor courses. Are there any way to actually this can be done in different institutions by their own instructors? What is the roadmap?
Yes, we train you people. If you have about 5 to 6 people who are interested, your hospital can be one training center.
Okay.
If you train others, it is all right. If you do not have time, you can train your own people because you will be having about 200, 300 people to train.
We have 1,000 nurses in each hospital. We have 2,000-3,000 staff.
I will tell you, we are coming with the program actually. And first of all, we train you people, about 6 people. And in turn, you can train them.
So if somebody is already a AHA certified instructor, also they need to go through the same IRC training?
Yes, otherwise the AHA will tell us that we have stolen their instructors. We do not want, and I wanted to tell these points again and again to them. So we wanted to conduct some online courses for those who have we have already done AHA courses. And most of these people who have done AHA courses, they are not bothered about the renewal of those courses. So even then, whatever that is written, the problem is some people they talk about the AHA guidelines of 2010 or 2015, and they say that I'm a cardiac anesthetist, I'm something else. It's all right. You know everything. You know the drugs. You know, and even our the shocking pattern also is little different from when AHA starts giving 200 joules. We always advise them to start giving 110 joules only because of the limit the damage of the myocardium by the shock itself, and it is well documented. And the other PowerPoint you can read in that.
Yeah, I've seen that, sir. The variation in joules and the variation in some
Yeah.
of the components. The second part is, suppose any of the institution gets an accreditation from the IRCF that the institution has a appropriate training personnels. When they locally train, that will be a part of IRCF where they get they have to pay, or what is the roadmap, sir? at this point? This is regarding institutional training. Training. So if the institutions are accredited and they have instructors, that IRCF and the ILCOR
We will make you one a CRTC. We will give access to our website, and whenever you train, you can inform us and get some books from us. And after that, you can directly take download the certificates for all of them. That will be there.
IRCF and will give the certificates to the individuals who are trained at us.
No, you will give the
Training,
certificates.
yeah.
And otherwise, it will go to his email ID.
Okay. IRCF charges for that, sir? Any amount?
Actually, for BCLS, we are charging 550 rupees for the book, and we pay the GST and we pay the courier charges. And for CCLS, we are charging about 1,000 rupees.
So that's the initial part. What about this rural layman training when we mass?
Layman training, we are asking you to give it free.
Okay.
We give it free, and we have a portal for that you can give them the certificate free of cost.
Okay. So suppose as a group, as a team, we go and deliver the resuscitation training to the rural school teachers
Yes,
or
yes.
community, we can give them a certificate from ICRF.
Yeah, yes, yes.
So, for example, I think we are all living in many communities.
Yes,
where
you will be conducting some camps and all, no? On behalf
of thousands of people are in communities, in a gated communities or in the villages, where some of them are interested to get trained. So when we train them, most of the time the certificate will be from the hospital or local. But now if we have a IRC CF,
it is an internationally recognized thing, and it will be. Actually, there are about 4 or 5 retired IAS officers with whom I have worked. I was additional director of health. I worked in Hyderabad for some time. All of them, they know that I am doing this. Why don't you send somebody to train our gated community and all? They said, okay, sir, you give me some time. I will come, stay there for 2-3 days. I organize these people. We do it because we have to improve ourselves. We have to help ourselves.
So I think you have a very hard task in your hands, sir. We are talking about training approximately 60 to 70% of the population, or maybe close to 50% if you're talking about adults only. We are a country with 140 crores of population. So it's only 2% of the population who knows maybe medical fraternity, or those are paramedics who actually may belongs to 2% of this population, sir, medics and paramedics. They are only knowing this.
No, actually, to train the medical faculty and doctors is little difficult. They have a lot of fallacies and superstitions or something like that. They think, even some people think that they have to give intracardiac adrenal injection when there is a cardiac arrest. So it is very difficult to change their brains. Okay. It is very easy
habits,
to
the habits and the beliefs, the old habits and beliefs.
Yes.
and their supremacy. They think they are doctors, so they understand it much better.
Yes, yes, yes. They already know it.
Siddharth, anything else from you? We are talking about community education. We are talking about paramedical and medical education, certifying them at a basic reachable cost. And I think, sir, this also needs a public awareness in many
Yes,
areas,
yes.
not at the medical fraternity.
You take up on through your hospital, and your hospital has got good access to the health minister also. Some of my colleagues in ISA Telangana, they say we'll take you to Harish Rao and we do that and all, but they don't do anything. And I tried a lot. Now I have made this EMRA as a training center. But I made a capping. It should not be more than this. It should not be. You cannot charge more than this. Otherwise, there is no use.
No use. It is again another AHA.
Another AHA. What is the use? And you should be completely 100%. Manasa, Vacha, Karma. You have to train. Otherwise, not for making.
How do
a
you
show.
monitor this quality, sir? How do you?
That is also we are developing the quality monitoring. Also, we are writing. If you come as one of the task force members, I will be happy because I have people. These two, three people are very busy now. Rakesh Garg is an editor, and
Chief editor
he has to attend the ILCOR meetings every 2 weeks and all. Now I want to bring some new blood. I have some people from Kerala. I have some there. I wanted to take either intensivists or the cardiac anesthesiologist or fully working intensivists or ISCCM members on the pediatricians. Pediatricians already they are doing their job, and the Pediatric Association of India has developed their own training course that is on BCLS and all. I said you limit yourself to the PALS and pediatric part. How to resuscitate the pediatric and all those things. So now,
wonderful vision for you, sir. I think you should continue this a positive thing which happened to the Indian Research Council or Resuscitation Council now. And as you said, at the bottom, basic level, school teachers, students, that's one area. Families, communities, villages, another area. So I think if we target them, the out of hospital cardiac arrest compression only phenomenon can be a big game changer in the field.
We can reduce the broad dead patients to the hospital.
The other thing which you raised, sir, which I wanted to emphasize again, this all will help us in out of hospital cardiac arrest. I think this basic fundamental principles are more focused on out of hospital cardiac arrest.
Yes.
What we have seen in hospital cardiac arrest, if it is because of a cardiac arrhythmias, ACS, VFVT, we have seen there is a good reversibility with chest compressions and defibrillations when it is done appropriately. But if it is a non-cardiac arrest, including a patient who has a respiratory arrest followed by a resuscitation, the outcomes are, in spite of there is a code blue team, very aggressive resuscitation, the ROIC achieved, but the outcome, the discharge with a fully cognitive function and
without any residual.
So my assessment is, in spite of a very efficient code blue activation and attendance on a CC cameras and a trained personnel also, we have seen the outcome in non-cardiac origins cardiac arrest situation has been very difficult. So what we have done in our hospital, sir, we have realized at this point that once the patient gets a cardiac arrest in a hospital, the outcome is dropping down to bottom low, maybe less than 10% patients who go home in a normal walking state. So we made a MET call activation or rapid response team activation very robust. We realized that is the way to go ahead. We created a mu scoring system. It was there before. It was everything there in our documents. NABH and every accreditation is, but the robustness, the understanding of that to the nursing teams and the resident doctors and the paramedical personnel was not efficient. So we keep on training them for almost 6 months, and we went through a repeated assessment till they passed that MET scoring assessment. And then we give them a small incentive of 500 rupees that you have cleared MET. And sir, we have achieved in a 700-800 bedded hospital in Secunderabad, Yashoda, where we actually admit lung transplant, liver transplant. We do around 200 liver transplant and a complex cardiac onco patient. There was a 0 code blues. We achieved 0 code blues. And that was unimaginable to us. And it is on record. Sir, we can hide everything. We cannot hide code blue because code blue is a
all
public
your experiences can be shared in our workbooks.
We have recorded around every month we have 3,000, 4,000 patients. So this IP admissions, how we trained, what was the game changer, what was our training module, how was assessment done, who did it, and what was the outcome. So how our MET calls gone up from 5 to 50, code blues dropped from 10 to 0. And later on, there were 1 or 2 incidents. Again, we had code blues. We could not make it 0, but we achieved it to the bottom low, sir. And that is again, as you rightly pointed out, preventing cardiac arrest in the hospital should be re-emphasized in many situations. So we will send you that complete article for your journal, sir. That will be a quality journal to us.
You send me your address, I will send you some books as samples. And on that, I will call you again to one of the task force meetings.
So, sir, as an organization, I think we will discuss that, sir. As an organization, just before this meeting also, I was talking to our managing director regarding this program. He was so glad. As an organization, we will come forward. This is an organization where around 4,000 beds were available in this city of Hyderabad, and there are many satellite centers, and they will be more than happy to be a part of Indian Resuscitation Council Federation to help in remote places.
We call it as a comprehensive resuscitation training center, and we'll label it. And I also requested the Google, you have to inform when there is a restaurant on the road you are locating. Like that, when there is a availability of AED, you should locate it.
AED availability.
AED availability, how far it is. I've written because we have to take these things and we have to write. Probably they will come out.
Can any center who has already AHA enabled center can also be a IRCF center?
Even 108 EMRA is now for training center.
So the same center can be a center of
no problem. Actually, they write it. You should not take this and that and all. They write it, but if you take it, they cannot say anything. Even the Siddhartha Pendleton Siddhartha Medical College has got American Heart Association and ours. They are training.
Okay, sir. I think the sharing of your experience, the sharing of your vision and knowledge is inspiring, sir. I think we speak about very complex, high-profile, sophisticated equipments, but many of the situations, these basic life skills saves more lives than many of them. So, and this vision for this, I think, is needs a salute to you. And you rightly been called as a CPR man of India. We are proud for you. And being a part of this Telugu state is again more encouraging and proud moments for all of us, sir. And we, from our bottom of heart, thank you for being a part of this program and enlightening us on this journey and creating this awareness, sir. Thank you for being here, sir.
Thank you. I'm very happy to be associated with you because many people, even from somebody has commented from Philippines and somewhere.
Yes, sir.
People are listening. Not only that, it will be a good thing. People should come and take it because we are also offering free of cost for the lay people and school children. That is, and nowhere in the world is offering a free training. No, people like you as a CSR measure, you can try in some of the villages when you people go for conduct camps and all those things. And it will be helpful. First of all, many people do not like, they want something else than learning CPR. So whatever it is, tomorrow, of course, I am addressing the FM radio. I called all the medical students here. I'll teach you. Of course, principal, the vice chancellor, or the DME, all are my juniors. So, and they listen to me. They, whatever I say, they follow me. And it is made compulsory for all the medical doctors to take the MBBS graduates to take training of the BCLS, and then only they will get their MBBS certificates in AP.
I also thank Dr. Siddharth, who has been kind enough to be a part of it and presented this presentation. I think Siddharth also takes a lot of learning points.
You also please share your complete address. Address means with PIN code and mobile number. Otherwise, whatever I send,
we will take Siddharth for our
courier will
further,
not take.
Chakra sir, we will take Siddharth for our further inputs also.
Yes. You will be our coordinator.
Thank you.
Thank you.
for your presence, Siddharth, and
Thank you, Siddharth.
conclude the session. Pawan, can you close the session?